Well, good afternoon, everybody. Thank you so much for being here. It's a great honor. Of course, I'd like to thank the AAO for inviting me. And today I'd like to speak about ankylosed teeth, who are always a big problem in orthodontic practice. And I'd like to speak about how we can solve maybe this problem. So I'm a full-time professor in Düsseldorf, Germany. If you ever are around, please visit us. And I did the postgraduate program in orthodontics and oral surgery, and I'm an active member of the Ankylosed Society. I'm a little bit biased. I'm a big fan of mini implants, especially in the anterior palate, and I do some courses and meetings about this if you're ever interested. So let's come to alignment extrusion of impacted teeth. Using dental anchorage, we always see some side effects. Adjacent teeth will be intruded, molars will tip, and this is always what we don't want to see if we want to align and extrude impacted teeth. And the situation becomes even worse if we have ankylosis. This is, for instance, a patient with an ankylosed upper left canine, and you see a severe tilting of the occlusal plane. Of course, this is a horrible scenario. So what can we do to avoid these situations? First of all, how can we fix it? How can we get out of this situation? In this patient, she was not willing to smile anymore. We used the ankylosed canine, and this is a take-home message number 1 of my talk. Don't extract the ankylosed teeth too early. Use it as an anchorage. In this situation, we used the ankylosed canine to extrude the adjacent teeth. In the lower arch, we used 2 buccal tads. And this is what we learned in the last 20 years. Buccal tads, they can survive, but we need a minimum age of maybe around about 15. So don't insert them in young kids. The failure rate is much too high. So again, lower arch, 2 mini screws, an elastic chain to intrude the teeth in the 3rd quadrant, and in the 2nd quadrant we extruded the adjacent teeth to the ankylosed teeth using an open spring, as you can see right here. So these are the follow-ups in this patient. Took around about 7 months to get from left side to right side, and now she is happy to smile again, before and after in this situation. Again, how can we diagnose these ankylosed teeth? Of course, we can do this percussion test we are all familiar with. I strongly recommend this Periodontal test. From my point of view, this should be available in every orthodontic office. You can diagnose an ankylosis very safely. Okay, so how can we avoid these side effects that occur if we are using dental anchorage? Again, we are using, especially in the upper arch, mini screws in the anterior palate. It's a very safe insertion site from my point of view. We call this best insertion site T-zone. Maybe you heard about this very recommendable insertion site. And we can either now go for direct anchorage or indirect anchorage. If you want to see more, I recommend one of our papers. This is, for instance, one by Manuel Nienkamper. Again, direct or indirect anchorage, both is possible. Depends a little bit on the age and the bone quality, etc., etc. In adults, we are using 1 mini screw. In children, the bone density is not so high, so we are using more and more 2 mini screws for alignment of impacted teeth. This is, for instance, a situation with 2 impacted upper canines before and after alignment. And now it's an easy case that we can finish with brackets in the short period or even with aligners. And the more we are using aligners, the more we are using these auxiliaries. The idea is to make a difficult case into an easy case that can be finished with aligners. We call this BAT, benefit for alignment technique. It's a nice combination to transform a difficult case into an easy case that can be finished with aligners. This combination was even last year on the JCO. It's a nice clinical journal, and my recommendation, check out these clinical papers in the JCO. So sometimes we have many impacted teeth. Of course, in these situations, we have very sophisticated mechanics, but I don't want to bother you with these super difficult cases. Today, I want to concentrate on ankylosed teeth. In most of the cases, we have just one ankylosed canine. So what can we do? You saw super nice and very good lecture by Sylvia about the path of decision. In our university, of course, we have a little bit different strategy. So what can we do? What are many orthodontists doing? We are luxating and try to align in a conventional method. However, there's a high risk of re-ankylosis. Maybe you move the tooth 1 millimeter and then there will be stop of the movement. Yeah? Additionally, you have side effects on the adjacent teeth, some more side effects of the adjacent teeth. What else can we do? We can take out the ankylosed teeth. However, if you take out this ankylosed tooth in this infra position, we mostly have a big defect of soft and hard tissues. We can go for osseous destruction. We have a couple of cases. You cut the bone. Dr. Kim will talk about this topic after my lecture. We make this segment, and after the latency period, we are going to move the whole bony segment into its final position. Of course, it's quite invasive from my point of view, and you have the risk of damaging the adjacent roots if you cut the bone like this. So I'd like to introduce you today in my lecture about this periodontal distraction. So we are not cutting the bone, we are more or less stretching the periodontal fibers, all right? And we learned this from my good friend Eric Liu, this PDL distraction. Eric has introduced this in the horizontal dimension. These are the first papers. Why did they do this? They want to speed up the treatment. Okay, so in a bicuspid extraction case, they want to retract the canine, not in 1 year, but in 1 week. To make this possible, you have to remove a lot of bone, of course. And maybe this is the reason why not many orthodontists are doing this these days, because it's a little bit risky from my point of view that you damage the root of the canine. Additionally, it's a little bit bulky, to be honest. This is a distractor, yeah? But after 1 week, you have moved your canine into the posterior position. To summarize, this is a horizontal periodontal distraction. Okay, you can move teeth very fast if there is no bone in the path of the moving teeth. And we thought what Eric is doing in the horizontal dimension, maybe we can do this in the vertical dimension for our ankylosed teeth. So this is a protocol we have introduced. First, we have to do, of course, diagnosis. We have to check the condition of the tooth we want to align. Yeah? Is it worse to align this tooth? Of course, if there's a bigger resorption, we are not going to align this ankylosed tooth. So we are loosening the tooth. I can tell you it must be super loose. It must be so loose that you can take it out with 2 fingers out of its socket. Then, according to the osseous distraction, we are waiting for 1 week. We have this latency period, and after this latency period, we do this vertical distraction. And the speed is a little bit lower compared to conventional osseous distraction. It's just 0.5 millimeters each day. But very important is this speed. So we don't apply a force. We are moving the teeth with a speed because it's a distraction. We do see the patient weekly. The whole procedure takes about 3 to 6 weeks. So this is how we started around about 15 years ago. This was the first dental-borne distractor. It's a little bit tooth mucosa-borne. It's on the basis of a removable Schwartz plate or active plate. But again, it's fixed. You cannot remove it. It stays in place in the mouth. This is a pulley, the activation screw, and this screw is activated daily by the patient. Again, the goal is that the tooth is pulled out of its socket every day. Yeah, this is again the speed, 0.5 per day. So I'd like to show you now some clinical examples. Patient number 1, she had 2 bicuspid extraction. Of course, this is a horrible scenario. We take out 2 bicuspids in the upper arch and 1 canine is ankylosed. So what can we do? Take out the canine. I think this is, then you have 2 missing teeth in the second quadrant. So this patient was referred to me because the orthodontist was very desperate. What can we do with this canine? And usually this happens, you know, these situations, yeah, everything is moving, but not the ankylosed tooth. So we did the vertical PDL distraction, loosened the tooth, waited for 1 week. This is how it looks like after loosening of the canine. And then we pull it out of the socket with this special speed. After 2 weeks, 4 weeks. And this is the good thing about this. We are generating soft and hard tissue. The tissues are following. This is 1 year later. Patient after 2 years. I'd like to show you now patient number 2. Again, it was the upper left canine. This is the distractor in place, loosened the tooth, waited for 1 week, then we started to pull out the tooth out of its socket. However, in this patient, there was no movement at all. So this was the reason why there was this hook on top of the apex. So what have we done in this situation? We have removed the canine. We did endodontic treatment, and I can tell you it's very easy if you have a tooth in your hand. Endodontics is fun, yeah? And then we have put it back in its original position. Waited for 1 week, and then we started this distraction. Again, first we wanted to move the tooth into the right position. Second, we want to generate soft tissue. Third, we want to generate some bone. This is situation after in total 4 weeks. You have to hurry up a little bit with the final adjustments. Why? There's a high probability that the tooth will be re-ankylosed. Very important. All right? So this was after the distraction. 1 week, 1 year later, bone has been generated. So to summarize, I've shown you 2 patients with dental-borne distractors. What did we see in all those dental-borne distractors? First, adjacent teeth have been intruded anyway because of the orthodontic treatment that has been done before. Then we had some more intrusion of the adjacent teeth. To make a long story short, we had in some situations a tilted occlusal plane. So we said we have to change something, and we changed our protocol. We moved from the dental-borne distractors to the mini-implant-borne distractors. Why? We didn't want to intrude the adjacent teeth anymore. So this was the first patient with a mini-implant-borne distractor. We are usually using 3 or 4 mini screws. This is how the distractor is designed. It should be as rigid as possible. And again, we have this activation screw. First patient where we use this distractor, 20 years. And you know these patients, they have been in orthodontic treatment for many years. They're very desperate. Yeah? They want to finish, they want fast solutions, and they are so happy, even though they have this distractor in place for a couple of weeks, they are super happy, yeah? Because we can help them now. So make the tooth very loose, wait for 1 week, it's always the same story. 1 week, 2 weeks, And this is after 4 weeks. We are generating soft tissue, we are generating bone. But all of these teeth, they have a small defect. And mostly this defect is in the area of the cemento-enamel junction, as you can see right here. But most of the teeth, they survive. This is 9 years after distraction. You still see this small defect. Nowadays, we are moving into the digital workflows, and since maybe 8 years, we are doing everything digital. And I'd like to show you the workflow if it comes to this vertical PDL distraction nowadays in a digital way. So conventionally, we inserted the mini screws, then we took an impression. Nowadays, we do scans, we are using insertion guides. And I think especially if you start with mini screws in the palate and you don't feel so comfortable, these insertion guides may help you to give you more confidence to find the perfect position for the mini screws in the palate. I can tell you it's not a big thing. The palate is very easy as an insertion site. You don't have to care so much about damaging roots, etc., etc. So this is the first patient where we used this one-phase protocol. Again, interestingly, it was again the second quadrant and an ankylosed canine. So one-phase protocol means one appointment protocol. We are inserting the mini screws, and at the same appointment we can insert the appliance, in these situations, the distractors. This is a situation at the beginning. Again, loosening the tooth, it must be super loose. Wait for 1 week, and then we start with alignment and extrusion. And if you have this speed, the tooth cannot be re-ankylosed. It cannot be re-ankylosed in this period. This is after 4 weeks of alignment, patient after debonding. It looks okay. It's not perfect, but it looks quite okay from my point of view. So nowadays we are also using digital techniques for metal printing. Simon Graf is here. We learned this from Simon, how to design these appliances, and afterwards how to do the metal printing. This is what we are doing now on a regular basis for expanders, for distalizers, for mesializers, but also for super special appliances like these distractors. Using these CAD/CAM techniques, we can nowadays design these mechanics as rigid as they should be. These distractors should be super rigid, so we can design the dimension as we want them. So this was a patient. We used in this situation a so-called two-appointment workflow. That means we are first inserting the mini screws, and then we do a scan. So we don't use a guide, and mostly if you are inserting 3 or 4 mini screws, we do this always in a two-appointment workflow. Why? The risk that the appliance is not fitting is much lower, okay? So 1 or 2 appointment workflow depends a little bit on the amount of mini screws that we are using. And the more mini screws we are using, the more we are doing this two-appointment workflow. That means first insert the tabs, then do a scan. Yeah? We are using mini screws from our bibliography. We are matching this, and after that the mechanics is designed either by ourselves or by our technician. Now we come back clinically to the clinical situation, loosen the tooth. It must be, again, super loose, wait for 1 week, and then we fix the distractor. This is how it looks on the model. And clinically, yeah, using these mini screws with abutments, you can do many, many different super constructions. They will be fixed with small fixing screws. So these mini implant systems, they have inner threads. So you can exchange your mechanics, what makes it, from my point of view, very comfortable for us and for the patient. So after 1 week of distraction, 2 weeks, 3 weeks, 4 weeks. And again, we have to speed up with finishing because risk of re-ankylosis is probably pretty high. This is a patient 1 year in retention. So, canines is easy from my point of view now, but we saw the lecture of Sylvia. How about molars? Can we also align and extrude ankylosed molars? The answer is yes, we can. It's not as easy, but it's possible. Of course, in these situations, we can take out the first molar, but if there are no wisdom tooth in place, PDL distraction is another option. All right? So, same story. Loosen the tooth, wait for 1 week, and then start with distraction. This was a patient that was specially referred to us for extrusion of the first molar in the first quadrant, and then the patient was sent back to the orthodontic office. Again, I don't like these dental-borne distractors too much, so nowadays we are using mini implant-borne distractors also for the molar areas. This paper was just published in the JCO from the University of Hamburg about how to extrude an ankylosed molar in the second quadrant. If you are interested, I recommend to check out this paper. Again, loosening of the tooth, wait for 1 week, and then start with the periodontal distraction. This is the patient at the end of the treatment, before and after, and from my point of view, a nice finishing. Patient at the end of the treatment. So how about the prognosis? In total, we made a small pilot study about this, published last year at the European meeting. Out of 18 teeth that were ankylosed, we were able to successfully extrude 16. 3 canines had some defects, and this is one tooth that has a severe teeth defect, so take-home message for us, do a cone beam CT in advance. Okay, of course it doesn't make sense to align extruded tooth like this, and but this is how it may look like. So what can we do if an ankylosed tooth has to be extracted? Okay, so sometimes the resorption is so big, so we take it out. Of course, we can go for a prosthodontic solution in terms of an implant or bridge. Transplantation is always an option if the space is not too big or not too small. Space closure is another option, and actually, especially in young patients, I'm always looking for space closure. Of course, there are some dentists telling us, you cannot close the space, the function will be not good, but we know this, of course, from Marco Rosa and others. There is no big risk, or the risk of TMD, periodontal issues, etc., is not higher if you go for space closure. This is a recommendable study. If you have patients with missing laterals or missing canines, we can go for space closure. There is no risk for TMD at all. You can show this patient to your referring dentist, all right? So what can we do in these situations? We, in the upper arch, are using sliding mechanics. This is a nice video made by my friend George Faber. We have published a lot about this mesial slider, and I'd like to show you now this mesial slider device in a patient with an ankylosed canine. And this ankylosed canine had a big defect. So this periodontal distraction doesn't make sense at all. So this is how the patient was referred to our department. What is the first thing that we are doing in these situations? Of course, it's crystal clear. We are disconnecting the wire with the ankylosed tooth, and we say to the patient, please come back in 3 months. And this is how it looks after 3 months. The adjacent teeth have leveled. But again, now we have to take care about the ankylosed canine. And my recommendation again, do a radiograph analysis. Nowadays we have these cone beam CT devices on a regular basis. So check out the condition of the tooth, and if you have A severe resorption, like in this patient, this distraction that I have shown you doesn't make sense at all, okay? It doesn't make sense to distract and to align this tooth with a big defect. So we take it out. But again, if you take it out, they have a big defect. So it's not easy for a dental implantologist as well. And my recommendation, especially in young kids, think about space closure. Of course, it's a little bit more time now, but the patient doesn't need a dental implant for the next 80, 90 years. All right? So this is after removal of the ankylosed canine, and she voted with her parents for space closure. This is a mesial slider in place. She was a very nice patient, so we added this pontic. You have to reduce this pontic. And the patients like these kind of treatments. I can tell you why. They don't have to do anything. They just have to clean the appliance, but it's not visible for their friends. They can still do pictures, smile for Instagram, etc., etc. It's the same story. Made a difficult case into an easy case that can be now finished with aligners. And this is, of course, not possible with aligners only. You get primarily tipping of the molars. Okay? So this is the finishing now with aligners. Radiograph after space closure. And the next step and the last step is to reshape the first bicuspid after intrusion that it looks like a canine. And from my point of view, this is a better solution compared to a dental implant. Dental implant where you always have problems for the next 80, 90 years, especially in the aesthetic zone. We learned this from Björn Zachrisson, Marco Rosa, Björn Ludwig, and many others. So go for space closure. I think this is one of the main take-home messages of my talk. And again, I personally like to treat patients with aligners, but the more difficult cases it's not possible to use aligners only, so hybrid techniques are indicated in these little bit more difficult cases. And I think this is a nice strategy to modify a difficult case into an easy case that can be afterwards finished with aligners. So, 2 minutes left. I'd like to come to my take-home messages of my lecture. I'd like to introduce you to this PDL distraction. We learned this from Eric in the horizontal dimension, and we can do this also in the vertical dimension. We learned that not all teeth survive in long term, especially those with bigger defects. So my recommendation, do a cone beam CT before, check out how big the defect is. And if the defect is only small, maybe 1 millimeter or 1.5 millimeters, we can go for this distraction technique and generate soft and hard tissue. So even if the tooth has to be extracted in long term, our implantologist will be happy. Why? We have generated soft tissue and bone for him. So he will love us, okay? Even though you don't need him maybe at second one, he will be happy in long term. What else did we learn? We started with this tooth and mucosa borne distractor on the basis of a removable Schwartz plate. However, we saw there's even more intrusion of the adjacent teeth that we don't want. So nowadays, I think it's from my point of view recommendable to use mini implant borne distractors. And in the anterior palate, we have the best insertion site. We need mini implants where we can fix a super construction on top. What else did we see? And this is the path we are moving on. We are digitizing these workflows, so we are not taking impressions anymore. We are doing a scan. And if you want to do the mechanics in the upper arch and the palate, of course, Don't forget to scan the palate as well. And nowadays we can order these appliances like we order aligners. Yeah, just upload it. For instance, you can use this Tadman service. You approve the appliance, and then you will get a insertion guide if you want to, and the appliance, and you can insert both in just one appointment. If you want to see more, this is our university website, the QR code. You find many, many papers about expansion, distalization, etc., using mini screws in the anterior palate. From my point of view, it's a gift for us orthodontists because this is so reliable. If you have some more questions, maybe a case that you want to share with me, is this maybe a case for vertical PDL distraction? This is my email address. And of course, I'd like to invite you to Düsseldorf. Every year we have a nice meeting. This year we had it just last week. I think it was a very nice meeting. Next year we will meet in May. If you're using social media, I can recommend this benefit application site. We are sharing nice ideas, combo mechanics. It's, I think, also super interesting. And don't forget to vote for this meeting, this lecture. This is the AAO QR code. And of course, at the end, I'd like to thank you so much for your kind attention.